microelectrode that we use during surgery, and the other one is a deep brain stimulation electrode. So the current density is very high right next to the microelectrode and decreases almost exponentially as a function of distance from the electrode to very low current density, a few millimeters away. So with a microelectrode less than a millimeter, probably even 0.5 millimeter, you can have thresholds for stimulation of cell bodies, and also less than a millimeter you could stimulate the axon surrounding it. But when you move beyond 1 millimeter, you are not stimulating a whole lot of neuronal structures. For deep brain stimulation, again, the same sort of thing holds true, but the decrease in current density is less steep. And so, again, within a millimeter, you can, within half a millimeter, you can have thresholds for stimulation of cell bodies, but the thresholds for axonal stimulations and the distance from the DBS contact are higher. So you could stimulate axons surrounding a DBS electrode, which are a few millimeters away from the center of this electrode. Another concept that I want to bring here is that in general, electrical stimulation inhibits a cell body and it excites an axon. And if you stimulate cell bodies over time, they adapt to this stimulation, while axons are less adaptable to electrical stimulation. And so once we establish that a lot of the mechanisms underlying DBS or electrical stimulation effects are mediated by axonal stimulation, is there an evidence that we have some off-target effects of electrical stimulation in the brain? And some of the initial work coming out of, again, Toronto and Dr. Razai, looking at the activity in bold in terms of fMRI signal change in DBS on and versus off state, and they identified several areas which were off target and had changes in their bold activity, including lateral thalamic wall, basal ganglia, and S1. Similar results using the PET studies, efficacious versus non-efficacious stimulation, and you could see clear evidence that there is M1 activation with efficacious stimulation versus the non-efficacious stimulation. So this is another one of the seminal works that looks at the structural connectivity of the DBS contact that is efficacious. And again, it points towards this area being, the efficacious area being connected very well with the rest of the tremor network. And so in order for us to have good clinical outcomes, the electrode contacts within the tremor network, which are able to modulate the function of this whole tremor network, are the ones that are more efficacious. And so then this begs the question, are there any biomarkers for good clinical outcomes? So the Klein et al. Compared the structural connectivity between areas that were efficacious versus non-efficacious stimulation. And as you can see, the efficacious stimulation shown here in red, it has more connectivity with primary motor cortex M1 and then cerebellum along with thalamus. So this points towards a structural connectivity that is mediated through the dentatorubro-thalamic tract and the thalamocortical projections from the IM nucleus to the motor cortex. So this tract system, if you will, and a electrode, DBS electrode in contact within these tracts is a biomarker for good clinical outcomes after tremor surgery. And there is evidence of that from focused ultrasound telemotomy as well. So Dr. Jeff Elias and Dr. Winter Mark's work here in patients who had telemotomy, they looked at changes, the fractional anisotropy changes in the brains of these patients to identify which networks were finally affected after telemotomy. And you can see that primary motor cortex M1, thalamus, of course, the site where the sonication was performed or telemotomy was performed, and the contralateral cerebellum. And so there was decrease in the FA values in these areas over time. So efficacious thalamotomy lesion kind of results in changes within the entire tremor network. And so again, same sorts of idea coming from thalamotomy literature as well, that the dentatorubral-thalamic tract and the thalamocortical connections are the primary target for good tremor control. And again, they took it to the next level, looking at the degree of changes in these areas and changes in the tremor score. And you can see the more the change or the FA change over time, the higher improvement in tremor scores. Again, kind of reinforcing that accurate identification of this area within the brain is kind of key to having good clinical outcomes in these patients. And so we know that we have biomarkers for good clinical outcomes, and we understand the anatomy of the tremor network. Are there any areas that we should avoid? And so again, I brought in the Shelter-Brand Watt and Atlas. As you can see, the area in green is the ventral intermediate nucleus. The area in red is pyramidal tract, which is involved with a lot of corticofugal fibers for motor control, and so we should be staying away from this area. And the blue fibers are or the blue area is the sensory nucleus VC, and so we should be staying away from this area as well. So the tractography-based method that we developed has 4 steps. And the first step starts at identifying an appropriate DTI sequence. As there are specifications that we made sure that all the patients had in terms of their imaging. So it's a 60 direction scan that had a slice thickness less than 3 millimeters. Ideally, you would like a voxel in these DTI sequences to be a 2 millimeter isovoxel. And so 2 millimeter isovoxel is clinically feasible. You have to kind of balance between scan time and how much the patient can tolerate, because these patients have head tremor as well, and so you necessarily don't want them to have a scan which is 20 minutes long. And so typically a 60 direction, a 2 millimeter isovoxel would take you somewhere between 8 minutes to 11 minutes depending on the different imaging specifications. And then once you have the right sequence, then we did correction for eddy currents and motion artifact. And then the key that we identified was having a precise co-registration between the structural T1 MRI scan and the DTI sequences, or the B0, or the directionally encoded color map. The T1 typically has a voxel resolution of 1 millimeter by 1 millimeter by 1 millimeter, and so that's why it's good to have a precise co-registration between a structural T1 and the B0 or the DEC from tractography. And a lot of this work was done using a clinically approved tractography platform by Medtronic, StealthVis platform. It uses a streamline algorithm to compute tensor and propagate these tracks. It's a very simple algorithm. So coming back to precise co-registration, we looked at an envelope around VIM about 3 centimeters. We had the focused ultrasound sort of treatment envelope in mind, and so then we identified 10 structures within this envelope that we wanted a precise co-registration, and the structures we identified were anterior commissure, posterior commissure, anterior commissure right here, posterior commissure right there, then the splenium of the corpus callosum, then the colliculi, these structures right there, and then the superior cerebellar peduncle in this location, and both the fornices. And so we looked at the precision between T1 and the tractography sort of DEC overlap, and if 7 out of these 10 anatomical structures were within less than 2 millimeters, we accepted that as a good co-registration. I want to highlight that the precision of co-registration between anterior commissure in a T1 and DEC is slightly off because of some artifact from the sphenoid sinus, and so something to keep in mind. Once the co-registration was done, then we tracked the pyramidal tract and lemniscus. So I want to remind again that these 2 tracks we identified we wanted to stay away from. And so pyramidal tract we identified by putting an ROI in the peduncle and M1 motor cortex. And then for lemniscus, we use the dorsal columns in the brainstem and sensory strip in the motor cortex. The key that for a precise sort of tract propagation was all the parameters for tracking were standardized. So the FA stop value of 0.2 typically, gray matter has this FA value less than 0.2 and white matter has more than 0.2. And then we kept the seed density at 1, and the tracking angles were kept at 45 degrees for pyramidal tract and 60 degrees for lemniscus. Once we tracked these pyramidal tract and lemniscus satisfactorily, we moved to the next step by aligning these images in the ACPC plane. The step 3 is the key where we identified the VIM region of interest, the ROI. And so assuming that a sonication thalamotomy lesion is 5 to 6 millimeters in diameter, we wanted to have the center of this ROI 3 millimeters away from a pyramidal tract and lemniscus borders. So the first step was to identify the border of these two and place a ROI 3 millimeters away from that. And once we had the ROI placed 3 millimeters away, we tracked the structural connectivity to verify the connection. So this is sort of an inbuilt step to verify. So the hypothesis is if this is a VIM ROI, it should have a connectivity to the motor cortex and the cerebellum, dentatorubrothalamic tract, and thalamocortical connections. And so this next slide kind of reinforces the methodology. Again, as you can see in red, the pyramidal tract, we created a border for that, then lemniscus border for that, and to bring in an element of precision, we created a small circle with a surface area of 28 millimeter that would give you about a 3 millimeter radius, and we placed a ROI in the middle of that, and then confirmed the structural connectivity of that to motor cortex, as you can see in a coronal and an axial slide, and then dentate nucleus. And so I mentioned earlier that the tractography algorithm that we were using is a streamline algorithm, and so it has challenges in terms of resolving fibers which are crossing. And so most of the fibers we could see were from ipsilateral cerebellum, but from tracing studies we know that the dentatorubrothalamic tract is contralateral. But the algorithm constrained us from that, and so we could see some fibers crossing over to the other side, and we were excited by that. But I wanted to highlight it for future investigators that you would see most of the fibers coming from ipsilateral dentate with this algorithm. Once we were satisfied that the VIM ROI is in the right position, we then exported these images to FrameLink, which is again a Medtronic-based platform for standard targeting for stereotactic procedures. And then we co-registered it to T1 images again and calculated the coordinates of the VIM, center of the VIM ROI, and use it for our surgical procedures. So for the overall study, as I mentioned, we carried it out in 2 separate cohorts, the imaging cohort and the operative cohort. In the imaging cohort, we had patients with essential tremor and healthy controls. And so there was a stepwise sort of quality control process. So we said, out of all the patients we had, how many had the appropriate DTI sequence with a slice thickness less than 3 millimeters? And so we lost, few sequences and few imaging subsets from there. And then we looked at the accuracy of co-registration, because head movement can put your co-registration off. And so again, we lost a few controls there. And then finally, to have a quick check at the quality of a DTI sequence, we looked at if pyramidal tract and lemniscus are trackable in these or not. In a separate operative cohort, we did 6 patients with essential tremor and tremor dominant PD, and we looked at the accuracy and the validation of these imaging findings. So going to the findings, what we identified was as compared to standard targeting, which is a formulaic method where, based on previous experience, folks have concluded that about a 25% distance from posterior commissure, the 25% of AC-PC distance from PC is where this ventral intermediate nucleus is typically on an average. We found that based on DTI targeting, it's about 2 millimeters anterior to that. And so instead of a 25% ratio, it was more of a 1/3, 33% of the ratio. Then as far as the lateral coordinate goes, again, about a millimeter more lateral than the standard coordinates from the ventricle wall. So it looks a little bit different, but the key part is captured in this slide that shows that there is a lot of variability. So the top panel is patients with essential tremor, bottom panel is controls, and this is the lateral coordinate distance from the ventricle wall, and I plotted it against size of the third ventricle. You can see that, as expected, all of us are wired differently. So the location of this VIM within ET patients as well as controls is very variable. Again, kind of confirming that this technique kind of captured the individual patient anatomy a little bit. Again, this is a slide showing that if you look at the distance from the ventricle wall between essential tremor patients and controls, it's about the same. Same with anterior coordinate, where you can see that there is a lot of variability. So for patients with a anterior commissure, posterior commissure AC-PC length of 27 millimeter, you could see that there was a wide range of where this nucleus could be in different patients. Again, kind of confirming that it's kind of capturing the individual patient anatomy in these patients. We also saw, interestingly, that there was a difference between ET patients and controls as well, in terms of where this nucleus is from distance from PC. So on an average, it was slightly more anterior in patients with essential tremor than controls. We don't know the significance of these findings, and we're looking at it in a larger cohort to look at what these findings signify. Then Guyot's method, a French neurosurgeon did observations about the location of VIM and came up with a formula as to where this nucleus might be, and we compared it to this gold standard sort of Guyot's method, and the tracks kind of confirmed where Guyot predicted the location of VIM to be at. Now, the next part of the study was validating these imaging findings in an operative cohort. And so, as I mentioned, 6 patients with ET and tremor-dominant PD were undergoing surgeries. We tracked and identified tractography-based VIM. And so these are 2 figures, as you can see. On the left-hand side is a microelectrode track. As you can see, the blue arrow kind of signifies that. And the location of this track is 6 millimeter anterior to posterior commissure, which is the standard sort of target. And I've colored the dentatorubrothalamic tract yellow and the lemniscus as blue. So while we are more posterior, you are seeing both dentatorubrothalamic tract and lemniscus. And the findings are, we have plotted on the right here, from the tip of this microelectrode, which is 5 millimeters above the target, to all the way 2 millimeters below the targets. So when we were 5 millimeter above target, just touching the dentatorubrothalamic tract, you started to see tremor reduction. And as the electrode kind of moved within dentatorubrothalamic tract, you continued to see tremor reduction. But as we were getting close to the lemniscus, we started to have sensory phenomenon. Patients reported numbness in the arm, and then as we moved even closer, you started to see almost hemibody numbness in these patients, kind of confirming that the imaging findings were in line with the electrophysiologically what we were saying. Now, when we move the track 2 millimeters anterior to that, and as expected, you would have lesser lemniscus, and again, imaging showed you that the lemniscus component kind of decreased here, and dentatorubrothalamic tract you could see more. And again, the same findings. As we started to touch the dentatorubrothalamic tract, you started to see tremor reduction, And at the bottom, you had tremor arrest without any sensory phenomenon. So moving anterior gave you more efficacy without having side effects. And once we came out of this, we saw hemibody numbness again, confirming that the electrode was close to the medial lemniscus. So the Euclidean distance between, or a 3D distance between surgically where we identified VIM and where imaging identified VIM was 1.6 plus minus 1.1 millimeters. So it was a good accuracy. Considering the voxel size for tractography is 2 millimeters, we were happy that it's kind of in line with the error for imaging. Now this is all the tracks kind of summarized together in one slide, and you can see these different tracks within dentatorubral-thalamic tract in different patients. And so there were a total of 9 trajectories in 6 patients, and 8 of these trajectories showed improvement, and 1 trajectory that was outside of dentatorubral-thalamic tract did not have any tremor improvement, while the ones that were inside or within this sort of biomarker, we had tremor improvement in these patients. So looking more from a mechanistic standpoint, we started looking to the electrophysiological correlates. So what do these tracks signify from intraoperative electrophysiology? And so this is a composite figure. You can see a patient MRI with a atlas overlaid on it, and the tracks are overlaid on it as well. Once your electrode trajectory enters into the structural connectivity of TVIM, you start to pick up cells which have a higher firing rate. When you're well within these tracks, you see the typical VIM neurons, which are large amplitude, large firing rate neurons. And once you're outside of it, again, the firing rates go down. This kind of image captures the final location of the DBS electrode in relation to the structural connectivity of VIM. So again, 6 patients, 9 tracks. We recorded a total of 73 cells. 20 cells were kinesthetic cells, and 26 cells were tremor cells. And then we analyzed 27 cells without any artifact for spike analysis. Of these 27, 18 were within these tracks, 5 were dorsal to it, and 4 were ventral to it. The major limitation is that these are not big numbers. This was an initial study. And then for the pictures that are coming in the next few slides, what we did was we normalized the length of the VIM trajectory across subjects. So when we say we were at 1, that means we just were at the top of the VIM, and 0 means the bottom. So within this 0 and 1, you would see a lot of findings in the subsequent images. The first interesting finding was that a lot of kinesthetic cells were located in dorsal part of these connections. And so this is, I'm sorry, this is a busy slide with sort of a small font, but as you can see, the kinesthetic cells are the blue triangles. And a lot of these blue triangles were within the first few millimeters when the electrode entered into the VIM. And so the normalized depth was 0.95, so it is in the dorsal part of these tracks that a lot of kinesthetic cells were. While the tremor cells were in the ventral part, and so it's 0.63, and this result was statistically significant. So the blue diamonds are the tremor cells, and a lot of these blue diamonds were well within the tracks. So kinesthetic cells at the top and tremor cells in the middle of these tracks. And so the first slide, we were looking at the firing rate of the mean firing rate of the neurons as we enter into the track. So above the track, the mean firing rate, 15 hertz, typical sort of thalamic cell, and then almost the same when we are at the top. And once you are within the track, the firing rate kind of jumps about 10 hertz, so 26.6 hertz within the track, and again it kind of slows down and again increases in the VC, or the sensory nucleus, when the trajectory comes out of it. Again, I want to sort of orient everybody. So on the y-axis is the firing rate, on the x-axis is how the electrode is moving through the tracks, and 1 is the top of the track, and 0 is when you are out of the track. So when you're at the within the tracks, there is about a 10-point jump in the firing rate of the neuron. So these tracks are showing a unique electrophysiology. These could be a marker for a unique electrophysiology. And kind of opposite to the firing rate that we saw, the burst index, which is we calculated using the Vitek-Kenyuki method, kind of a surrogate for information transmission. You could see that there was higher burst index towards the bottom of these tracks, and so this result was statistically significant. As you move through the tracks, there was high burst index towards the bottom of these tracks. Again, showing that the tracks are a biomarker for a unique electrophysiology. We looked at the beta power changes through the track, and you could see that as you moved, again, within the tracks there were peaks within the beta power, and there was a trend, but not statistically significant. As far as tremor control goes, we looked at tremor reduction. So if there was, on a 4-point tremor scale, if there was no change, 0%, 1 point less than 50% reduction, 2 points more than 50%, and if somebody had improvement of more than 2 points on a 4-point scale, 100% tremor reduction. And so the zones for tremor reduction were at the edges. As compared to above the track, as soon as you entered, there was a significant increase in the clinical sort of effects of stimulation. Again, confirming that these tracks are showing a unique electrophysiology plus clinically meaningful area. So in future, we are expanding this work into larger cohorts, looking at tremor outcomes, side effect profiles, and even going into targeting the tremor somatotropy, looking at arm tremor, hand tremor, head tremor, those sort of things. And then looking at expanding this technique for different targets in the brain for modulating motor network in Parkinson's disease and anterior nucleus in epilepsy. So these are very preliminary results from Ohio State. We have had 7 patients with essential tremor who have completed the follow-up. And so what we have defined intraoperatively, if you, for a 10-second sonication and you achieve a more than 55 degrees centigrade temperature change, if you see a 50%, more than 50% tremor reduction on a scale, not subjectively, then you're in the right place. And the most important thing we add to that is that these patients, when we are doing this sonication, should have no side effects related to pyramidal tract and should not have side effects related to medial lemniscus. So a small, kind of well precisely placed lesion without side effects should give you efficacy. And so this is the sort of intraoperative benchmark that we use when we target these patients with tractography. So overall, our operative times have been about hour and a half, so 80 minutes. A number of sonication about 13, and we only optimize our target with this technique for controlling tremor topology. So if somebody is having more distal control, less proximal control, then we will move. So we never had to move for any side effects related to sensory changes or pyramidal tract problems. And so these are the patients, and the first column is the demographics. The second column, you see the distance between where tractography identified VIM versus the final lesion epicenter, and this distance is pretty close. We are targeting right in that area. And the next column is distance between standard target and the final lesion epicenter. So the standard targeting kind of is quite a bit off, and this is statistically significant. And the results it changes. We only have short-term data, so I apologize. We'll have more long-term data in future, which will be the key in looking at the usefulness of this technique. But for short-term, we are seeing good tremor reduction in these patients using tractography-guided targeting. Again, for GPi, we have kind of developed this technique, and the junction point of the NSA lenticularis and the structural connectivity to the cortex from GPi seems to be the efficacious spot. And I quickly wanted to show you this sort of intraoperative slide when I target these patients with tractography. So when the electrode is 13 millimeter above target, you see a typical globus pallidus externus sort of neuron firing, low amplitude but high firing rates. And once you are within the tracks, the firing rate tremendously go up, and you continue to see that. And coming out of the tract, you start to see motor cells again. So if you follow sort of a stepwise quality control process, we are seeing these sort of results again replicated in GPi as well. But the usefulness and the clinical sort of effects of this technique remain to be seen in future larger cohorts. For anterior nucleus and thinking about the epilepsy network modulation, this is work I did with Dr. Lozano, where we looked at the efficacious site within the anterior nucleus in patients who had anterior nucleus deep brain stimulator. And again, this is a Shelter brand Warren Atlas showing the anterior nucleus proper right here, rest of the thalamus, and the mammillothalamic tract coming in and plugging in the ventral part of anterior nucleus. And the efficacious site appears to be within the ventrolateral or the basolateral part of anterior nucleus in these patients. And the connectivity, not surprisingly, of this region is mesial frontal and again the temporal sort of connectivity, mesial temporal connectivity. So again, these type of connectivity maps can help us even within anterior nucleus precisely localize the area for efficacious stimulation. Finally, I want to thank my mentors, Dr. Lozano and Dr. Azai, for helping me with these projects and thinking through some of these research questions and helping develop these projects. I want to thank my colleagues, Francesco Sammartino and Dr. Nick King, for collaborating on these projects with me. Thanks again.
Questions from the online audience. Could you please comment on how this method compares with the approach of Surgcalis Incorporated?
Yeah, so thanks for the question, and I got your kind of email, and I had not known about this company before. There are several sort of methods that folks have looked into for identifying VIM. And unfortunately, there is not a whole lot that they provide on the website, and so we haven't compared this method with the method from Surgcalis. But what we have done is compared this method using a simple sort of deterministic algorithm to a probabilistic tractography algorithm, and we have kind of incorporated these results in the upcoming publication in movement disorders. And so the results are quite comparable. And I tend to kind of look at this technique more favorably because it helps me understand individual patient anatomy and helps me target the biomarker for a good outcome, which is the structural connectivity of VIM. And so more than just looking at this subregion within the thalamus, it allows me to identify these tracts and target those. And the other important distinction it brings in is it helps me look at pyramidal tract and lemniscus and stay away from those and hopefully avoid side effects related to, say, weakness or paresthesias and those sort of things.
Another question from online. Can you please comment if this method can be applied to the STN as well?
Yes, this is a very good question. We are working on it. STN is a little bit challenging because there are a lot of fibers which are crossing and a lot of fibers which are curving around STN. And so using a simple sort of streamlined algorithm, it's very difficult to resolve those fibers. But yes, with the next version of the tractography algorithms, we should be able to resolve these fibers and should be able to identify the biomarkers for good outcomes. There is some initial evidence to suggest that the direct connectivity of STN to motor cortex probably is the biomarker for good outcomes in these patients. And so, for sure, we are moving towards that to develop a technique for subthalamic nucleus. Yes.
This is John Snell from the Foundation. So in using DTI and tractography, how does this change your clinical workflow in terms of for the day before and so on? And also, once you have computed the target, analysis, how do you transfer that to your actual treatment delivery environment?
So good question. So I do these type of analysis about a week ahead of time because I showed you in some of the patients the imaging sequences were less than ideal, and so you want to pick that up way ahead of time. And so I do this tractographic sort of pre-processing a week in advance, and it takes about between 1 to 2 hours of my time, and then that way you can plan the procedure. And if there are any problems, we can acquire different scans, or if we, at least I know that I wouldn't be able to use those sequences. For the DBS part, it's easy to sort of use these tracks live, if you will, for surgery because it's a Medtronic-based targeting system, and you can seamlessly export these tracks into the targeting software. We have tried to do that for our focused ultrasound procedures as well, and we have been successfully able to kind of incorporate, but there are kind of limitations on how many sequences you can import, and so we are able to import the final target that we identify into the system, and that we can use. Then, for sure, when I do the calculations after aligning an ACPC plane, if we are not able to incorporate the images, we can at least know the exact measurements. As far as the procedure overall goes, I feel that this has helped me streamline the procedure without having to change the targeting too much, either because of any side effects coming from paresthesias or efficacy that I'm not happy with. So it allows me, within the after verifying the sonication target, once we start to hit 50 degrees, 10-second sonication, it helps me understand exactly the tremor efficacy is good, and I see no side effects, and so on.
All right. This concludes today's webinar. Thank you all for joining us today, and stay tuned to our newsletter and website for invitations to future webinars.